Elder Schultz, UAMS Pediatrics. Sheena and I have talked about this in the past, and I want to make sure that the PCPs are rightfully incentivized for doing the developmental screening that is recommended by Bright Futures as well as written into EPSDT. I think there's a risk that if they're not incentivized, or at this point in time, if they find the child that needs services, that's going to run the bill up on the child and may disincentivize any clinician from doing the recommended screenings. Has that been thought through, or and perhaps Sheena, you've already addressed that with them and they've got a good answer?
No, good answer.
One more back here.
Amber Bryant with Ozark Health Home Care. I just have a question. Where's home health or home care going to fall into this? You talk about transitions of care and things falling through the cracks and making for sure that the patient is vested in their care and that they're going to actually do what the doctor wants them to do. Are we going to be privy to that coordination of care or that team approach that you talk about that's going to be in the physician's office? Are we going to be privy to that in the home? Because, I mean, we see them where they're at. And we see all of the bare naked stuff, you know, literally, a lot of times. So, you know, patients will always tell you, oh, yeah, I'm taking that medicine, but, you know, we know whether or not they actually do that.
Brian Coulthard, Health Resources of Arkansas. I was curious, do you expect to see the management of the care coordination to extend to the co-occurring behavioral health, mental health, substance abuse domain? And if so, where does that leave the community mental health centers and the private providers that are doing that now?
Brad White, Pettigene Medical. In regards to the physicians that are involved in the program, will they be able to maintain autonomy for either selectively adding or excluding patients from their panel?
I'd like some information on whether Medicare will be participating both in the PII and in the medical home concept.
You may be aware that the developmental screening measure is one of the Child Health Improvement Program, CHIPRA, Reauthorization Act measures, and that is something that was on the table for inclusion of quality metrics related. So I think that Dr. Golden kind of went through some of the quality metric targets. It's not one that was selected just yet, not that it's off the table necessarily, but again, that balancing act between administrative burden and the reward for that. So I think, Dr. Schultz, I think that is something that we need to continue to work on. I know that Dr. Kuo is here and has addressed that as well, and Dr. Ochoa as well. So I think that it is something we will continue to have discussions about as we go through the process. Is there anything you want to add on that, Dr. Golden?
Well, yeah, when you start looking at these metrics, we are committed to, in a sense, we want to lower the ceiling on the costs, but raise the floor on the quality. So we certainly do want to maintain and make sure the essential services and the appropriate services are given. So your point is well taken, and we need to monitor these things to make sure that people get what they're supposed to get, not just avoid costs. So we agree with you.
And let me just transition right into the question about cherry picking. So do you get to pick your own patients? That's obviously a concern for us as payers, and obviously with the Medicaid program. Are we going to put a reimbursement system or an incentive system on the table that actually encourages people to avoid the high-risk patients? Actually, the opposite. If we're successful, we will be creating an incentive for you to look for the high-risk patients, because we're going to be able to measure who they are. We're going to be paying more per member per month for them. And by the way, guess where the real opportunity for shared savings in the 95% circle around your office reimbursements is? It's the high-risk patients. That's where so many of those other 95% dollars are. So unlike the present, we actually are hoping that you will cherry pick the high-risk patients, and we're trying to create exactly the level playing field that enables that to occur. I'm being a little bit facetious. If we're successful, it'll actually be entirely neutral, which will likely mean some will choose to focus on the higher, some on the lower, and the financial opportunity and reward would be would be comparable.
And let me follow up on that just a little bit regarding current Medicaid. Again, now Medicaid patients choose the physician. So there's not an assignment of patients to a physician. The patients choose the physician. So I wanted to make that clear. And yes, there will continue to be where the practice or the physician can set his or her panel size. There's not going to be a mandate of a number of panel or patients that you'll take, but with a enhanced per member per month and the opportunity to have gain sharing, it's our express intention, our hope that providers will open those panels up even more for more Medicaid beneficiaries.
Let me pick up on a couple of the questions, home health and also care coordination in the mental health. For the higher risk patients to successfully be cared for, and then for the providers to actually successfully share in the gains, there is a brand new incentive for the primary care provider to reach out to home health or to make sure that the community mental health centers or others that are specialty providers are part of that team and helping manage the patient's care. Conversely, the primary care provider in the future will lose more if they are not connected and the patient does end up in the emergency room or hospitalized. And when I say lose, it's lose the opportunity for gain sharing. Their costs will be higher and therefore their gain sharing opportunity will be lower. So it is intended to set up an incentive, not to force any integration of the delivery system, although I think there will be some integration, but to have the financial incentives aligned so that the quality of care, the coordination for care, and the inefficiencies where we can avoid service use when it wasn't needed, the financial incentives are aligned to optimize those outcomes. We had a question on Medicare's participation, and let me just hit on that one. The State Innovation Model grant that was awarded in January to the state, we're one of 5 or 6 states that are, one of 5 states, Vermont, Minnesota, Oregon, Massachusetts, that's right, there's one more, and Maine. So a lot of northeastern states, Minnesota, Oregon, and then Arkansas sits down here in the belly of the beast. We were one of 6 states that were awarded a large grant, somewhat over $40 million, which is not the entire cost, doesn't count the per member per month payments or other things that the payers have committed to actually over the next 3 years implement the Payment Improvement Initiative. The Arkansas Payment Improvement Initiative includes 2 big components. Let's not separate them. One is the patient-centered medical home, and the other are the episodes that are being delivered together. The picture that I have in my mind is kind of a spoked wheel. The patient-centered medical home is the center of where the action is, and the referrals go out to an episode on a spoke when there's a specific need, and the patient then comes back to the hub for ongoing chronic care management and so forth. So anyway, Payment Improvement Initiative is inclusive of both. Medicare has a major financial commitment, not only through the SIM, the State Innovation Model proposal, but also in the Comprehensive Primary Care Initiative that they made last year. And our expectation is that we slowly pull more commitment out of Medicare to more fully participate both in the episodes and to broaden their participation from the 69 CPCI clinics to essentially support all primary care clinics that are serving Medicare beneficiaries in the next 2 to 3 years. I will say we want it to be Arkansas controlled, not Medicare controlled, and we'll just acknowledge that some of the CPCI frustrations are shared among the payors and that we will continue to advocate for the CPCI participants to get this to work for Arkansas in an Arkansas way.
The last question we have is regarding home health and transitions of care.
Yeah, I think Dr. Thompson actually addressed that. We aren't going to play Soviet system here and dictate how the market comes to what's a pretty obvious solution. You got folks in the home. That's a pretty obvious way to help manage a patient. We know that. We don't pay for it right now. We're going to put money in the right place in front of the right folks, and we believe that will occur, but we're just not going to try to dictate how.